Welcome to Mejo's docuseries on health entrepreneurship. Entrepreneurship in healthcare is vital for addressing Africa's unique challenges and creating sustainable solutions for communities across the continent. In this series, we explore the journeys of three extraordinary leaders: Dr. Ian Clark, an Irish-Ugandan physician, entrepreneur, and philanthropist who founded the Chiwoko Hospital and the International Medical Group in Uganda; Dr. William Mafam, a South African ophthalmologist and founder of Vula Mobile, the oldest African health tech company connecting hospitals to specialists; and Tony Nativ, a Ugandan pharmacist, activist, and founder of Garden Health Pharmacy, one of the largest with over 19 stores. Their stories reveal the lessons, challenges, and triumphs that define healthcare entrepreneurship in Africa. Through their experiences, we aim to inspire the next generation of changemakers in healthcare. The first steps are often the hardest. For these leaders, starting out was a journey of bold decisions and learning curves. Let's dive into how their entrepreneurial journeys began and the seeds that grew into impactful ventures.
When I was working in Ireland, I was a family doctor and I was a bit bored. So I started a couple of other businesses when I was there. So I wasn't a stranger to being an entrepreneur. And when I came to Uganda, then some of that experience, and this is one thing I've learned in life, always take the season you're in, and then always try to garner as much experience and learn things from that season, and you will never know when that will become useful. I just finished reading Steve Jobs' autobiography by Ericsson, very good biography by the way, and you know, the story is told of how Steve Jobs, when he went to I think Brook University, he wasn't a good student, he didn't settle. In fact, he left university, but then he used to go back. He hung around the university, he used to go back and do classes, and one of the classes he did was in calligraphy. And that resulted in what we have now in all the different font styles and so on in our keyboards. And you'd think, well, you know, the different things that Steve Jobs did contribute to his life in different ways. And you see that, and I think that's a lesson for us all to take. Whatever season you're in, get the best. I'm always telling my staff, it's not about, you know, you're just here and picking up a pay packet. How are you developing as an individual in this particular season, this job that you're in?
Yeah, that's very interesting. I relate to Steve Jobs, that part of his story, it was very inspiring. It's like everything adds up, eventually every little skill adds up.
See, your life's like in building blocks, and so you keep building, and you're building a wall, you're building a house, and so you build on something you've had before. But the other thing, and again you see this in Steve Jobs, is your experience may not be just linear. You may not just do, you know, say now you're an intern and you're doing some research. So you could go on and, you know, you build, but you keep essentially in the same field. Or maybe a better example would be, let's say you train as a surgeon. You know, so you do your undergraduate, then you do your postgraduate, then you start practicing as a surgeon, and then for that career you probably just continue. You know, is a linear development, but not all careers are linear like that. And mine hasn't been, and I think some people assume they're going to have a linear, progressive career, and yet today's world is not like that. There's too much disruption in this world. AI, you know, the digital world has come along. AI has come along, changes a lot of things, and so you have to be prepared to learn those things and then see where you go next. And sometimes that has been a question of starting again. For me, there's been a lot of starting again. A lot. Because when we were in Ireland, I was middle class. You know, I had a nice house, I had a good job, nice car, kids at private schools, and and a mortgage. And all of those things tied me into, you have to stay in Ireland, earn this money to pay your mortgage, send your kids to school, give them the opportunity in life. Nothing pointed to coming out to the world, to Uganda. In fact, when I spoke to people about that at the time, they were just like, are you nuts? You know, what's, you know, and yet at the same time, when I came to Luero, the experience I'd had in Ireland helped me, not just the medical experience, but other business experience, helped me to do what I was doing in Luero. So I was driven by, let me say I've always been driven, as I'm sure you all are, by having a purposeful existence. And so when I had done that 6 years in Chuoko, it was very meaningful because we were able to really build something in a post-war period, bring back hope to that area. But there was a time I had to give it up, you know, and pass it on to the next person. It's run by Ugandan doctors now. I still sit on the board, and it's a great place. But so that's always a question: how you move on to the next step? Do you give up what you're doing? You know, this is your project, and a lot of people want, you know, they call it founder's syndrome. You need to hold on to that thing, or you're prepared to move on to the next thing. And I think I've always been prepared to move on to the next thing. But moving on to the next thing is often, sometimes you're not sure what it is, or you're not sure, you know. So when I finished the Chuoko project, and I did my master's in public health, and my kids were then back at school in near London, then it was a question of, now what do I do? Because it was, you know, it would have been easy for me to become a family doctor again, live in suburbia, and yet my experience had all been dread diseases, HIV, Africa. So coming back out again and starting a clinic was a difficult decision because it wasn't the sort of, you know, it wasn't obvious that that's. But what was driving me was I didn't want to take all that experience that I had had in Chuoko, an experience of HIV, developing countries, tropical medicine, that was all my training, and then just go back to checking blood pressures in little old ladies in Buckinghamshire. You know, I mean, nothing wrong with checking blood pressures, but somebody else can do it. So I think sometimes if you feel dissatisfied and you're driven, you sometimes are prepared to pick up and start really at the bottom again, which is what I did, because it was like a little clinic. I did have to raise the money for it. I had to mortgage, I had a house, and I had to increase the size of my mortgage, get some money, buy some equipment, start this clinic, and start from zero, because I had 0 patients. You know, I think I did have 1 patient the first day, so that's always a start. I really started with 1 patient, and I would have days when I had 3 patients or 2 patients or something like that, until people go. Because I'm selling the service, and one of the mistakes I think that people make, I've seen it all over the place, but I've seen it in Uganda. Someone says I can offer service as a, I don't know, an eye surgeon or as a GP or whatever. So they set up shop, but they only go there sporadically. And the fact is, if you sell, we sell either goods or services. You know, we sell this pair of glasses, or I sell the service of, you know, the optician service of being able to, you know, give you the right prescription for your eyesight. So I was selling the service, and if I wasn't there was no service. And I couldn't just delegate that down to someone else. So I was particular about that, and it rapidly built up. And then while I was doing that, one day a guy walked into my office. Actually, remember it was just closing up, so it was like 7, because I would work, you know, in the mornings, and then I would be at lunchtime. I'd be doing other things, and then 4 o'clock to 6 o'clock, like that was my evening office hours, or 7 o'clock. So it was about 7 or 8 o'clock. I was closing up, and this guy came in and said, "Would you be interested in doing capitation? You know, treating patients in capitation?" And I'm kind of like, what's that? And capitation is basically where you receive a certain amount per year, and then you look after that patient. So it's a kind of insurance. And he was the HR manager from the American Embassy, which was a lot smaller then than it is today. And the international people all had their insurance, international insurance, but the local staff, they wanted to provide a medical benefit for them. And of course they were finding this thing where people were bringing back false receipts, and they were going to a clinic and inflating the price. And so he knew, from his American experience, that you could do what he would call an HMO model. So he would pay a provider. He'd say, we've got 100 staff here, we're going to pay you $200 a year and per person, and we pay you on a quarterly basis, and you look after their medical needs. And that was mainly outpatient services. If they went into hospital, I would follow them up, but I didn't have a hospital then. And he said, I've been around all the clinics, nobody wants to do it. I said, why? I said, because he was offering something like $160 a year to look after a patient. And so guys would sit down and go, but if this guy comes 5 times a year, I'll have lost money, because $40 a consultation and drugs and stuff like that, and then he comes 5 times, I'm lost money. But my calculation was completely different. I had the setup, I had the infrastructure there, I had the staff, I had everything. So the only thing that his $160 was costing me was the marginal costs. The drugs, the lab tests, that was it. Otherwise I was there, my time was still there, my nursing staff were there, and so I reckoned if I was getting $160 a year, I was for 200 people, whatever it worked out to be, I was meeting all my fixed costs immediately, and I could make my, so I was like, yeah, I'll do that. That became the basis of my insurance. Then I opened an insurance organization, sort of modeled on what AAR were the first people who did. But it was basically on the basis of this American embassy contract, and then I started to sell that to other companies, and it was a kind of a medical insurance, but it wasn't really quite medical insurance, because you came to my clinic for the treatment. But that was one of the business aspects that really helped me to, because when people are paying school fees, they don't pay clinic bills, so that your income goes like this, yeah. But when you have a fixed income coming in from a corporate organization, in fact, you'll find now that sometimes in the international medical centers, probably 80% of their income is coming from medical insurance. But it wasn't called medical insurance then.
Chose to work with the Uganda Cancer Institute, and the way I ended up there was interesting. Before you finish pharmacy school, they ask you to do a dissertation, and I looked into adherence to antiretrovirals in young adults, and studied a lot of kids around, adolescents and that stuff, where they say, for you to get the best outcome on antiretrovirals, you must at least take 96% of these medicines. That's the stuff we're studying, looking at how that shook out among adolescents and young adults. So 2 kids that had participated in that study ended up getting cancer. Cancer would increase the risk of HIV. HIV would increase the risk of getting cancer by 400 times in some studies. By some studies. So kids ended up at the Cancer Institute, followed them up for treatment. We met this guy, Jackson Orem, and strangely, most of the breaks I've gotten in life have been out of random acts of kindness. I didn't have to help these kids access care, just like, okay, I'll follow you up. So we ended up at the institute. At the institute, people would line up from Thursday to Friday. You line up from Monday to Friday. Line up from Monday, you don't get to see a doctor. By Thursday is when you get to see this doctor. He gives you a prescription, you can't find, he gives you investigations and all that stuff. The next week you get a prescription, you can't find the meds in the market. if you can afford, the meds are not available. You have to get them from Kenya, put them on a bus. So I asked this guy, how do you then? He was the only doctor on duty, 15 nurses. I'm like, how do you? No pharmacist, no full-time pharmacist. You would get interns rotating there. So how do you live with yourself? Because the people who spend a lot of time waiting to see you after you see them, write for them these meds, they don't come back, or if they do, they get one cycle out of 6. A lot of them progress and die. It's like, well, this is our lot in life. This is what we've been dealt. We just are engaging government to see if we can find solutions. At that time, the institute was a small unit in the Department of Medicine. I think at the time, the head of Department of Medicine was either Professor Mayanja or Nakwagala, I don't remember, and Jackson was just under him. So I'm like, okay, I can come and work with you. So I asked Mr. Maserika, who was my boss as an intern in Makerere, to post me there for the remainder of my internship. So I worked with the institute, reorganized their pharmacy, pushed for more financing, pushed for breakaway from Mulago. We became a vote. We saw our medicine budget increase from like 50 million to maybe more than $2 million, I think, in like 18 months. We quickly thought through ways of, we had money for medicine now. We had money for buildings. We didn't have money to hire doctors and pharmacists. So we thought up something. We knew that members of Kampala Club, if you go to the institute now, there's that former private patients unit that still has a placard, I believe, for members of Kampala Club. So we knew that members of Kampala Club met every Saturday to, drink whiskey, talk about life. And I knew that the chairman at the time, Dr. Mbonye of Nakasero Hospital, would always tap Jackson to go and see VIP patients at Nakasero Hospital for free. So I figured, we had some goodwill there. So we asked him for a slot on a Saturday to talk about cancer. So all we wanted was to get money so we could essentially rob Peter to pay Paul. These rich Ugandans who didn't want to wait would then be seen faster and for a fee, and then we use that money to hire more doctors and nurses. And that's how it worked. So we went to Kampala Club one evening, spoke to them. Jackson gave them an elevator pitch, did a fantastic job. By the time we left, the late Tumusime Mutevile had probably donated like $50,000 or something like that. A lot of money, I don't remember the figure. But we partitioned the outpatients unit, put like 6 rooms, and started. That revenue allowed us to hire more than 50 nurses. In fact, when you go to the institute, a lot of their nurses are from one cohort of the diploma program. So we got like 50 of them initially on quote-unquote volunteer basis, but we're giving them like 150, 200,000 shillings at the end of the month. It was a lot of money at the time. Okay, not like a whole lot, but it could support someone who has just left school. And later the government absorbed them. Jackson made me the head of finance and administration at the time. Like for 1 year as they set up their structures. So essentially I was running that cancer institute. I think I was 24, 25. We wrote the essential drugs list for cancer for Uganda. We wrote their strategic plan. Put a lot of these things that you're seeing in motion. That structure that the guys now call the Uganda Cancer Institute were the ones who did the planning for it. And so it gives me great satisfaction to see it's gotten where it has. But also for me, it worked for me because it gave me access to a lot of these academics and scholars and practitioners from the West and all over the world in cancer care. And these guys helped get me into training programs. I remember I got a chance to go to Dana-Farber Harvard Cancer Center thanks to Ken Miller. and the Lance Armstrong Cancer Foundation. Then I got into the University of Washington. I did, thanks to the Fred Hutch Cancer Research Center, I did a fellowship in virus-related cancer treatment, and then got into the MPH program. Graduated from that. Suddenly I was back on track to being a professor. Then, as fortune would have it, between school breaks 2012, I came back to Uganda for a break. But before that, Grace had come to California. He had come to the US. I was on the West Coast. He chooses to land in California. I think it's the attraction of Disney and Hollywood and all that stuff. So I had to fly down to California to see him. Offered to buy me out of my interests in the two pharmacies under Vine. Settled on a price. Paid me some money. So that, I think, it's what I used to start Guardian. So I came back 2012 and just to say bye to these guys. So yeah, Pap sold, I'm no longer into this. Up there in Kavalagala. Kavalagala is 2 minutes from here, as you know. So after I said bye to them, I was walking down to the stage, to the taxi stage, to head out. I was staying in Chihuahua at the time, so I see this building that has space available for rent. I'm like, I asked Grace, is it okay if I set up a pharmacy here? Remember, I was just on a school break. And he's like, fine. So I walk into there, ask for the landlord. The guy tells me, yeah, Stanbic Bank is going to take the lower floor, but we are still negotiating over some fees and whatever extra money. I'm like, if you're negotiating, can I match their offer and then pay whatever the difference is in the disagreed, whatever you're not agreeing on? They're like, fine. They are going to pay for 6 months. Can you afford? I'm like, I'll pay you for a year. So the guy accepts. He says, okay, here is my bank account number. Make sure you put the money by Thursday. This was a Monday. I just walked to the bank, put the money that very evening, paid. Again, I didn't have a company name in my head. I wasn't going to be here to run the company. I just knew that that place could make money. I go back home after paying. Think about a name. At one time I'd been in the UK for a few. And I used to like reading the Guardian newspaper. And the Guardian newspaper at the time had a cutout section, like how you say Vision Health or New York Times Health section. So this was Guardian Health. And so my experience in the US, I'd seen that insurance companies actually made a lot of money. So I figured, I could set up an insurance company, but also do a vertically integrated model, which is I can own pharmacies, I can own clinics, I can own, like what Dr. Ian Clark tried to do with IHK and IMCs. So Guardian Health looked like a nice name for a company. I went, talked to a friend of mine who was a pharmacist with MJAP, MJAP, Makerere University, John Hopkins AIDS programs. Gave him 50% of the company in exchange for his time. I gave myself 10 and then 40 to my daughter. She was 2 at the time. I'd paid for rent, I'd gotten National Drug Authority authorization to operate a pharmacy there, and went back to the US. Get to March, the pharmacy is not opening. I asked the guy what's up. He was distracted with work and all. So I come back and he gives me back my shares. He wasn't interested. I think also he said. So got back my shares and we opened our doors on March 2013. I still remember the amount of money we made that day, 79,200 shillings. I still have those books up there. We had, we'd record everything in books. When I see guys here embracing technology, I'm like, I wish. So anyway, but what we did was we were the first pharmacy to brand, to pimp up a place like this, gypsum boards, 3D branding, thanks to my experience in the West. We would deliver meds 24/7. We would even deliver Panadol in this Muyenga neighborhood for no additional cost. So we became a darling of the neighborhood, and we quickly opened so many pharmacies this side on the south side of Kampala. Within 2 years, we're turning over more than $2 million. And the rest, as they say, is history.
When I came back to South Africa, and just before I went to Swaziland, I decided I would have nothing to do with media, nothing to do with technology. I would become a pure clinician again. And that's why I went to Swaziland to learn how to do cataract surgery and to conduct other eye care operations. And I guess, luckily or unluckily, the surgeon in Swaziland never trained anyone before. And he was an incredible surgeon. And so it was quite a new thing for him to train someone. And he thought that it would take him 3 months to train me. But obviously I was a very slow learner and it took me 10 months. But in that time, I got to see more of the ecosystem. So I specifically remember driving, we did outreach. We drove about 4 hours to one of the clinics. And there was a patient there who was actually a healthcare worker. And she had a huge tumor on her eye, and a conjunctival tumor. And if she had only been able to use something like Vula then, she would have been treated possibly even a year earlier. And I think it was things like that where I realized we have to do something. We can't just let this continue as it is. We have to find a solution. And at the time, Blackberries were the main cell phones. So the first version of Vula was actually on Blackberries. And then that translated into launching on the main app stores, which you see today. We had the idea in 2010, which is when the World Cup was in South Africa, the Soccer World Cup. And I thought that everyone would immediately recognize the need and help me build the system. And that was not the case. So I had a PowerPoint and I tried to sell the PowerPoint for 2 years and I didn't get any traction. Then we did a demo version on BlackBerry and that got a little bit of attention and a little bit of funding. And then I just started filling in forms. I think I filled in about 60 funding applications that first year, probably more after that. And eventually I got one bit of funding. So it was the equivalent of, what would it be? 2,000 US dollars. So not a huge amount of money, but you can do something. But the real point of it was that it was from the Shuttleworth Foundation, which is very well known in South Africa. Mark Shuttleworth was the first South African to go into space. He had sold a tech company for a lot of money. And the fact that we had his sort of badge attached to us meant that suddenly doors started to open. And so in 2012, a design company offered to give us some design time. And that helped me actually have an Android demo. In 2013, that demo version won a big innovation prize in South Africa. And that funding enabled me to launch in 2014. So although it sounds quick, it actually took me 4 years from the idea to having something I could put in someone's hands.